Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
So good evening. I welcome all my students for this class, and I'm very, very enthralled always to take this, I call it a short session of just 1 hour in which I can teach you as much as possible, especially about those topics which are asked in your examination. And this 1 hour, I want to make it as productive as possible so that you people are able to not just write down in the exam, but also equally prepare for your Viva, because there are certain questions which can come at any point in time. See, infections in pregnancy is always and always a very, very fundamental topic. And like I say, for a person like me who's absolutely clear and concept wise and serology and otherwise about infections in pregnancy, I would just love to take you through different aspects in which I can catch you and take you to one infection or catch you for another infection and take your Viva there. So if you caught with a person like me in your examination, it will become a little difficult for you, which is why I want you to just pay attention in this 1 hour, and you'll be able to understand one topic is going to be clear in your mind forever. So today we're going to be dealing with hepatitis in pregnancy. I have brought for you those things which are important for your exams. Let's begin with a little bit of introduction about hepatitis. So this remains the leading cause of liver inflammation and liver cancer. It might even reach a stage of liver transplantation, because that is the morbidity of your liver disease in pregnancy especially. Viral hepatitis affects or can affect members of all populations worldwide, and may mostly see pregnant patients when they ask you whether we can have food outside or drinks outside. This is why your guarded answer will be to avoid it, because food, like we say, so many hepatitis, they are fecal-oral route, foodborne, and certain viruses which otherwise are not that lethal become very, very lethal during pregnancy, and will reach that place as well. So there are 6 identified viral hepatitis: A, B, C, D, and E, and the most recently described is the G virus. Hepatitis A virus and hepatitis E virus. Okay, they're important causes of maternal infections in endemic areas. India happens to be one for hepatitis E, especially, and even A. And HEV is associated with considerable morbidity and mortality. And since I was from Gangaram, Delhi, we were one of the most pioneers and really good institute for liver transplantation. So we got this burden of hepatitis E in pregnancy, a lot of patients to see. So the mortality in case of gynae and obstetrics was negligible, except for these kind of patients. So hepatitis E patients have seen a real morbid condition, and many of them could not be saved. So the baby survived, but the mother could not be saved. That has also happened. So it was a very, very gloomy, place to be in, because just imagine we're sitting at the most developed tertiary sector, known for liver transplantation. And what more do you want for a patient with, fulminant hepatic disease, I would say, rather than liver transplantation, and still we couldn't save the patient. So this is really, really morbid, really big mortality associated with hepatitis E, and a very disturbing case. Hepatitis D virus is an incomplete virus, and it's co-infected with hepatitis B. So usually when a patient is seen with hepatitis B virus, always go for a complete serology and complete diagnostic modality, including hepatitis D viral antigens. And that can cause a disease which is far more severe. In fact, can lead to fulminant hepatic necrosis. So that's the worst thing, because fulminant, that means acute and very, very dangerous, and proceeding and into bandwidth proportions in very less time. Hepatitis G virus, and RNA flavivirus, it's named as human Peggy virus or HPG virus. Why? Because it causes a parentally transmitted infection of the RE system, the reticuloendothelial system, like spleen and all as well. Okay, now a little bit of introduction or recapitulation, I should rather say. So you have most important thing in hepatitis is the jaundice, right? So when you're dealing with a patient which is showing frank jaundice, it's classified into pre-hepatic, hepatic, and post-hepatic. Okay, though I can go on and on only on the introduction as well. But since a lot of, we are not going to be dependent in hepatitis when we know it is hepatitis regarding this, conjugated or unconjugated, it's only for those conditions in which we do not know that jaundice is because of what. in that case, do you start having this kind of discussion that whether it is pre-hepatic or it is hepatic or it is post-hepatic. What you first get to see is just the serology report that the bilirubin is high. Now, if bilirubin is high, you always see the TBR and IBR, right? Total direct bilirubin or indirect bilirubin. So conjugated or unconjugated bilirubin. So if unconjugated bilirubin is high, that means either the liver is damaged or the liver stuck. It's not reaching. Whatever it is, it's not reaching the liver. So there is a problem before liver, or there is a problem in the liver because of which unconjugated bilirubin is high. Okay. And post-hepatic, that means if once the liver has done its work, okay, it has conjugated the bilirubin. In that case, post-hepatic jaundice you'll have more of conjugated bilirubin. That funda should be crystal clear. So when you're seeing the report and the bilirubin is high, the next question is always, what are you looking forward to in hepatitis? Is it the unconjugated bilirubin or the conjugated bilirubin? So obviously the liver is not functioning. How can it be conjugated then? It is always the unconjugated bilirubin which is high in pregnancy, in case of hepatitis. Okay, that funda should be clear, number one. Number two, you should all know these values. Okay, total bilirubin over here is in micromoles per liter, but it's almost the same. Like, you just have to put a decimal over here. Things will be that it should be less than 1 or till 1. That's it, not more than that at all. Conjugated bilirubin and this unconjugated bilirubin, even if you do not remember the exact values, it's fine. But then comes ALT and APT, which is SGOT and PT. Now, sometimes I've seen students fumbling on what ALT is SGOT or ALT is SGPT. Okay, so that also is the other important thing, which I had put a slide on that. I cannot see it right now. Anyways, so ALT and AST is also there. Alanine aminotransferase, that value is very, very important. So it should be less than 45. Both of them, just remember, both of them should be less than 45 international units per liter. And in case of hepatitis, pregnancies like that, it goes above 1000. So anything which is less, let's say, around 100 is also fine. 200 is also fine. You can still think of your IHCP. But if a thing is touching 1000 or something like that, please, even 600 and above, please be hepatitis minded or something more catastrophic than that. You can't sit over it, right? Alkaline phosphatase increases in pregnancy. Gamma glutamyl transferase also increases in pregnancy, but not to those proportions as does increase in hepatitis. So with this background in mind, guys, let's start with the first hepatitis, which is hepatitis A. Hepatitis A, how many of us have really seen hepatitis A cases? But usually it is very, very common. It's very contagious, very common. And it's a single-stranded RNA virus. Usually all viruses that we have studied, all the RNA viruses, they were all single-stranded, right? So single-stranded RNA virus, and it's transmitted by fecal-oral route. Very important, fecal-oral route. Again, why? Because patients, they come to you to ask, I don't know what happened. Nothing. I did not do anything. I have not had outside food, and still I'm having this. Hepatitis A has come out to be positive. So the answer is at some point in time you did have. Okay. So it is actually from the fecal-oral route that it is transmitted. And of course, once it gets into one person, then from person to person contacts, vomit, exposures to contaminated food and water. Okay, so the fecal-oral route is very, very common, and then it's highly contagious because it spreads in direct contact. Okay, and especially in these areas where the sanitation is poor and the crowded living conditions are present. So mostly you will see in unhygienic conditions like slum dwellers and all, hepatitis A is very, very common. Now, there is acute infection. So once infected, patient can show symptoms like, now you tell me, in hepatitis, what kind of infection, what kind of different, symptoms do they have? See, all the hepatitis, they'll present you the same thing. The first thing to go will be the appetite. Okay, feeling of lethargy, loss of appetite, vomiting, very, very prominent. Fever might be low grade. Fever with chills, if at all it comes, then you should think about others as well, like malaria, dengue, and all. But when jaundice develops, first be thoughtful about hepatitis. So GI upset is a very most common factor. This symptomatology secondary to T-cell mediated immune response leading to inflammation, necrosis of hepatocytes. So our T-cell immunity activates itself, hepatocytes, because they are being infected right now by the virus. Those hepatocytes are being killed by the T-cells because they are damaged. That's how it all happens. The liver is getting inflamed. So liver is not working properly, because of which all these symptoms are emanating. So a large majority of patients, this is a reversible process without chronic sequelae. That's a beautiful line to be remembered. Hepatitis A virus, not bad. In majority patients, they're going to be all right without any chronic sequelae. Then comes the question of always diagnosing the disease, screening and diagnosing. So can you see a little bit of the small kit over here? Hepatitis A virus. Now, how many of us have seen these kits? Always, sometimes it's attached to the OPD paper and given to us. Kit for hepatitis B virus testing, hepatitis C virus testing, and now hepatitis A virus testing also. And if you can see, there are two wells. One is for IgM, one is to check IgG. Okay. So now it's very, very clear. With this picture memory, you will remember that hepatitis A virus is a diagnosis of serology. Always you remember that IgG is a long-lasting immunity. Comes late, stays late. IgM is a short-term immunity, comes and goes early in pregnancy. So it's always a marker for acute infection. I hope this thing is absolutely clear to all my students who are attending the class today. It's very important that you do remember that IgM is the acute immunity. It is always a representative factor for acute infection. Because HIV infection induces lifelong protection, and then a very important thing, again, so a lifelong protection against reinfection, and elevated IgG antibody would indicate a prior infection or a prior vaccination. Now, hepatitis A virus vaccines are also available. We can take them and we can go ahead and have this immunity. Like in last class, some of you had asked about the chickenpox vaccine. Yes, it's very much available by GlaxoSmith. And to be very honest, guys, it's very rare that in India things are not marketed. Most of the things which are available are marketed in India. So if suppose an examiner asks you and you're not very sure, confidently ask, yes, it's available, ma'am, with the reputed companies. But that's it. Be quiet after that. Sometimes the examiner is also not very sure. But seeing your confidence level, they understand that maybe she's got the complete information. All right. So just say that. So it's very rare that certain things, when I was talking about menopause, I spoke regarding some estrogen rings and estrogen patches, patches are also available, which might not be marketed freely in India, but they're all FDA approved. Hence, they can be thoroughly marketed, and staying in places as small 2-tier cities, you might not know. But places like Bombay and, those places in which the cosmesis is a very important concern of people, they are readily having a constant supply of all kind of estrogen preparations, especially local estrogen preparations like patches and rings, and specifically the ones who target for vasomotor symptoms, right? Not that they do not have any systemic effect. Of course, they do have, but they're all due problems. Anyways, getting back to hepatitis. So you have this serology, which is very, very important in hepatitis A virus. And very important, two lines are very important. First of all, it's a self-limiting disease, usually does not leave a chronic sequelae like a hepatitis B virus. But and the second important thing which you need to know is that it induces lifelong immunity. Once it gets IgG is formed, it usually does not let it reactivate or reinfect the patient, which is a very good thing. So that is all about hepatitis A virus. Let's come to its management. So obviously, see, viral diseases, when we talk, one good thing about all viral diseases that you don't have to remember the management, because there actually isn't. So even if you try to remember dosages or names or anything, none of them has been proven successful. Okay, except for a couple of factors in hepatitis C virus to a certain extent, but not in hepatitis A or B or any other virus. And so many viruses we studied in the last class. I hope you all were there in my class last time when I spoke to you regarding rubella and CMV and herpes and herpes zoster. We spoke about so many viruses, but the treatment was there for only a couple of them. Like in herpes, remember I told you what was the dose, and varicella zoster I told you what is the dose. Okay, it's close together. And couple of in CMV to a certain extent, valacyclovir. So again, we're back. So following diagnosis, clinical management is usually supportive, and to maintain comfort, adequate nutrition, adequate hydration, enough amount of bed rest. That's the only way to do it. Administration of immunoglobulins may improve the clinical manifestation of the disease if given within 2 weeks of infection, but this treatment is of no help in the acute phase of HIV. See, the problem with immunoglobulins, what are immunoglobulins? That's actually passive immunity. What is passive immunity? Come on, guys, I need to hear this out from people. What is the funda behind this passive immunity? I spoke, I think, a line or two when I was teaching you about chicken pox, right? And then there came a question regarding whether we have the vaccine available or not. So yes, it is available, but when do we usually give these immunoglobulins? When is a vaccine given to a patient? I need this answer for my dear students who are there in the class right now. Okay, a couple of you are there. So let me know how many of you can tell me what is the funda behind giving a patient this immunoglobulins. The patient is already infected, currently infected, or what? Yes, they are ready-made antibodies. Correct, absolutely. So when will you give these antibodies to the patient? When will you try to give this immunoglobulin to any patient? Answer is very simple. Come on, go in the chat box, guys. You can write. Answer, yes, you are right. Very, very close. Sometimes, the answer which the examiner wants, that those words exactly are not there. Absolutely, Meghna. See, my favorite students, very sweet, very nice. I love them. They are always there answering the class. I just want even the new people who are there to try, okay? See, when you try and you go wrong, you remember it even more. That's the idea. Guys. So make mistakes, learn them. Learn from those mistakes. All right, not totally. Sometimes, there are certain words which we want to hear, which we're not getting. You are right. All of you are right. What I want to hear is that immunoglobulins are usually given after exposure, not after the disease. Okay. So just try to remember about COVID vaccine. COVID vaccine was not given to a person who has COVID right now, who is fighting with the COVID infection. That COVID infection person was kept in the ward and given all other treatments, but not COVID vaccine. COVID vaccine, on the other hand, was given to those people who were exposed to that infection so that they do not develop the infection. That's the idea behind these immunoglobulins. So administration of immunoglobulins to improve the clinical manifestation of the disease given within 2 weeks of infection, in the sense, this I'm not completely agreeing with. Immunoglobulins, they are actually passive immunity. It is given to those kind of people whom we want to develop the antibodies rather than them developing their own. See, these are two different aspects. One is the vaccine, all right. Vaccine is the one which makes you develop your antibodies. One is immunoglobulins to be given to those people who have been exposed to the infection, not having the infection currently, exposed to the infection. So that you're giving antibodies from outside to them so that they can fight the disease if at all it happens. Are you getting me? They're two different components. I was very confused when I was a student. That is why I wanted the same thing to be transferred to my students here. Two different things. Vaccine is actually different than passive immunity, right? Vaccines are actually active immunity, and immunoglobulins are passive immunity. Immunoglobulins are already made antibodies, like my students have answered already. Beautiful, Aruna, and beautiful, Meghna. Thank you so much. So they have already made those immunoglobulins and they're giving it to you after your exposure, not after the disease, right? In the similar way, vaccine is given again to those people who are to be exposed to this disease, or you take it before, but you take it much before so that you give your body time to develop immunoglobulins or antibodies. And if you do not have time to make those immunoglobulins, passive immunity is given to you immediately, like the one I'm talking to you about. Within 2 weeks, they wrongly kept the word infection. It's actually exposure. Now, I'm going further, guys. If there is any doubt, please scribble it down on a piece of paper and I'll take those doubts towards the end of the class. I promise. Okay, I always wait for 5-10 minutes and then I leave the class. Hospitalization is reserved for patients with evidence of severe disease. Even in hepatitis A, you sometimes have coagulopathy, encephalopathy, malaise, asthenia, and you can always admit these patients and give them your due care in the hospitalized patients. There is practically no maternal to fetal transmission of HAV, as the anti-HAV and IgG antibodies present during the initial stages of HAV infection cross the placenta and provide protection to the infant after delivery. Very, very important. So there is almost nil HAV transmission. So you can safely tell your patient, go ahead, deliver child, go ahead, breastfeed your child. Your antibodies are going to give protection to your baby, and it's not going to be in any which way dangerous for your